What is the route to private practice in refractive surgery? I'm Lorcan Butler. This is the iViews podcast from iNews. Thanks to the sponsors of the show, Mainline Instruments. They provide unmatched service and unbeatable products in Eyecare technology. But just a reminder, this podcast is editorially independent. So I'm joined by Masara Laginaf. Masara, would you be able to explain to our listeners who maybe haven't heard of you, who you are and what you do?
Of course. Thank you so much for having me, first of all. So my name is Masara Laginaf. I'm a cornea, cataract and refractive surgeon. I'm based in London and Hertfordshire.
And in terms of your workload, are you doing more corneal work or more cataract at the moment, Masara?
It really is a mix of things at the moment. I would say that within the refractive space and within the cataract space as well, we've seen a slight move towards more lens-based procedures in recent years. And I think that's partly to do with the population that have more disposable income. So we're seeing more kind of RLE, refractive lens exchange surgeries and cataract surgeries at the moment. That being said, we are still doing a fair amount of kind of laser vision correction, implantable contact lenses. But a large bulk of our work now is actually insured cataract patients. And that kind of is the bread and butter of what we do.
And for maybe trainees who are interested in going into private refractive surgery, could you explain maybe a little bit about your path, or maybe kind of suggest things that people should be looking out for when they're in ST 3, 4, 5, 6?
Of course, yeah. And I'm starting to see more trainees kind of approaching me to find out how I've ended up in the refractive space. And I think you're seeing more trainees younger and younger, and at the earlier stages starting to think about their subspecialty and how they may kind of get into that route. For me, it was a little bit fortuitous in terms of how I got into refractive. So I never had a set plan when I went into ophthalmology as to what my subspecialty would be. And I think often it's shaped by the people you work with, the mentors that you have along the way and the passion that they have. And that really rubs off on you, I would say. So I originally went into ophthalmology straight from my foundation year, and I'd actually done a 4-month placement in ophthalmology at Watford, which was a great kind of base for establishing my knowledge. I then trained for 7 years in Kent, Surrey and Sussex Deanery, which for those who are in that deanery, it is well known for being an excellent surgical deanery. So there's a lot of access to surgery. We work across a huge area from Canterbury to Chichester. So it really is a huge area with a really interesting population of patients. The trainers are really good as well. So I had a really nice, broad range of experience by the time I got to the end of my training. And one of the first people I worked with was Tom Poole at Frimley Park Hospital, who is well known within the deanery as being very passionate about cornea. And so that was my first job actually within ophthalmology. And prior to that, I'd done an elective in Northern Ireland, where I'm from, with Johnny Moore. And as you know, he's a cornea, cataract and refractive surgeon. And I think the first operation I saw was a DSEC, which was just phenomenal as someone who was still in medical school. And I also had the ability to go to Cathedral Eye Centre, which is his refractive centre. And I also saw my first LASIK operation. So it's quite funny how it's come full circle. But I had that initial leaning and interest in cornea. And Tom is very passionate at Frimley about corneal practice on my first few grafts, assisted with those. And that kind of stimulated my interest in cornea. Throughout my training, it ebbed and flowed a little bit. I was still exploring other avenues. At one point, I thought I'd become a generalist and get a nice cushy DGH job and live happily ever after. Also thought about medical retina at one point because I thought that was really fascinating. But then it was Simon Taylor at the Royal Surrey who said to me prior to choosing my TSC, he said, "It's not what you know, it's what you can do. That's what's really important." And I was just about to choose my TSC, and I thought to myself, well, nobody else wants to do cornea in my cohort, and I'm quite interested in it. So I know that there's an open slot to do that subspecialty, which not everyone has the ability to do. But also I just thought, well, what are the skills that I can actually learn in that TSC? I'll learn anterior segment surgery, I'll learn trauma surgery, I'll be able to do corneal transplants, lamellar grafts. And I just thought, that's going to be such a brilliant skill to have, no matter where my career takes me. So part of it was that, and part of it was having the chance to work with Tom Poole again at Frimley. So I went back and did a year placement with Tom. And that was my final TSC, kind of my first fellowship, if you will. And that was also the year that COVID happened. So I think most corneal surgeons here and fellows at the time will know that corneal transplant tissue was hard to get your hands on. And that's when that really started to become an issue. And also, a lot of theatres were shut down for many months. And we were quite lucky in that we were able to reopen our theatres quite quickly. But that was kind of my grounding in cornea refractive. And then I knew I wanted to keep training. I knew I wanted to get more numbers because with COVID, there was a little bit of impact in terms of the amount of surgery we could do. But I had a really good basis at the end of that job. And it was really interesting. I do think things happen for a reason. And I actually ended up missing the deadline for a job application to a very, I won't say which hospital, but a very famous hospital for fellowships. And partly that was just due to my own tracking of the dates, and I ended up missing the date because the job actually came out much earlier than it normally did. And it was also my first time using tracked jobs. As a trainee, you're not really in the job market for 7 years, so you don't quite know how it works. So I ended up feeling very foolish that I missed that deadline. And I started looking at other fellowships that were available. And I even interviewed for CHEK at one point, which, as you know, is a high volume cataract provider, because I thought that would be a great experience post-training to become an adept high volume surgeon, even if it was for a year. So I ended up meeting Raman, who set up CHEK, really interesting guy, and ended up turning that job down, actually, and going for a fellowship with Alan Barsom at Luton and Dunstable. And that was quite fortuitous because I ended up doing not only corneal training, but also with Alan, I had the option of doing refractive surgery training, which is not something that's widely available in the UK. I know at Moorfields and Queen Victoria, they have a little bit of refractive work. And there's some places up north, like Hull, for example, Liverpool, have access to refractive surgery. But it's not something that's easy to learn. It's not something that's widely available. And often refractive surgery is within the private sector. And so trying to get access to that or have exposure to that is quite difficult as a trainee. So I was very lucky in a way that I missed that original fellowship application and ended up at Luton and Dunstable with Alan, because that opened a whole new world to me. So much so that I ended up having LASIK myself. I think it was within 3 months of starting, Alan managed to convince me to get rid of those glasses.
That's a leap of faith, isn't it?
Well, do you know what? I ended up having laser refractive surgery, LASIK, in 2020. So I had 2020 and 2020. And it was honestly one of the best things I've ever done, because I was someone who couldn't operate in contact lenses because my eyes would get really dry. I would wear glasses to see patients, but I would take them on and off every single time I used the slit lamp. So much so that at one point my glasses broke and I was on call one evening with half my spectacles kind of dangling off my face, to which my patients looked
very professional look.
They looked a bit disconcerted, I'm not going to lie. So I could suddenly just do away with all that. And it was amazing. I had LASIK on the Thursday at OCL Vision with Alan, which is his clinic that he set up with his colleagues Ali and Ramesh. And I was able to operate the following Monday, and my vision was pristine. It was so refreshing to be able to look down the microscope without my glasses on, without the reflections, without my glasses steaming up, especially with the masks that we were wearing during COVID, and without the dry eye from my contact lenses. So it was really an amazing thing to actually experience it myself as a patient.
And that must be so relatable and so easy for you to communicate with your patients, the advantages and disadvantages you just said about optical appliances, whether it be glasses, contact lenses, the rigours, the disadvantages.
Yeah.
Do you find that easy to be able to speak to the patients and say, I've done this and this is what we anticipate? Yeah,
and I think it helps them because they know, I know exactly how it feels. And not only do I know how it feels, but I know how it feels at OCL Vision where I had it done, because I had the same femtosecond laser. I had the Zemer Z8. I know how it feels on your face, on your eye. I know the pressure that you feel during that part of the process. And I knew all the steps that were happening at the time of the surgery, because by that point I'd assisted on hundreds and hundreds of cases. So I could almost feel the flow of the case as it was happening. So it was really interesting, actually, to experience it as a patient. And also I developed this profound sense of respect and admiration of what our patients go through, because I had a relatively quick, non-invasive procedure, whereas our patients who undergo, for example, cataract surgery or cross-linking, A, it takes much longer, and B, it's invasive. You feel a bit more pressure, water on the eye. And I had sedation on board. I had a lovely diazepam tablet, which was delightful. And most of our patients don't, especially within the NHS, don't get the option of sedation. And they're just going in cold turkey, local anaesthetic. And I remember going back to work the following week and just being in admiration of the patients.
Yeah, and it's fantastic now having that patient perspective yourself that you can kind of, align with their kind of, fears.
Yes. And I think what's really interesting is I love to travel, and part of the reason I love refractive so much is the benefit I've experienced having it done myself. And as a trainee in ophthalmology, I never really thought about having refractive surgery myself. It wasn't ever something that occurred to me because I thought, well, my eyes are really important, don't want to put them at risk. Also, contact lenses and glasses, I saw them as just my normal. They weren't something that I was trying to get rid of. Yes, they were a bit of a nuisance. Yes, I had so many issues with contact lenses, but I just accepted that as my kind of normal. And it wasn't until I started assisting on the surgeries and seeing the patients in clinic and seeing how profound the results were and how much it impacted them that I got a little bit of FOMO, actually. And I thought, I want to have that. So it was only with my exposure as a surgeon to refractive surgery that actually led me down that path. And I think from a marketing, getting patients through the door point of view, you realize, well, if I wasn't even thinking about it with my level of knowledge, how are we going to get the word out to patients that this is something that they should consider and that could massively augment their lives?
Time for a word from our sponsors, Mainline Instrument, leading in ophthalmic innovation since 1997. Mainline Instrument supplies premium ophthalmology equipment from global manufacturers, including Eyecare, Oculus, Tord Pi, Tomei, Optomed, Huvitz and Neats. From advanced diagnostics to surgical solutions, explore their products and services or book your in-clinic demonstration at mainline.co.uk. Mainline Instruments. Unmatched service, unbeatable products, unrivaled quality. You've mentioned a lot of mentors at the present moment, Masara, along your kind of career, and I see now you're travelling nationally, internationally, speaking at ophthalmological conferences. Do you think it's important that you give something back?
Definitely, yes. One of the things I've always liked to do is try and gather as much data as I can in the role that I have and working with my mentor. So Alan, I would say, is one of my main mentors, Tom Poole as well. And Alan was really my mentor into that refractive space. And often you just need someone to believe in you and to push you forward for opportunities. So some speaking opportunities are things that, for example, your mentor maybe can't make that meeting or make that talk. And so they will suggest you, whereas perhaps you wouldn't have necessarily got that offer. And that just allows you your foot in the door to then prove yourself and to say, look, I'm a confident speaker, I know my stuff. And in my role, I've always tried to find opportunities to gather data, present posters and presentations at conferences, and try to be part of the dialogue, particularly when it comes to new technologies or new approaches or techniques. And so that's something I've always tried to do when I'm going to meetings.
Yeah. Obviously, you're talking to qualified ophthalmologists at this stage. If you're talking to students, maybe people who are thinking about getting into private refractive, where could they learn more? Where could they kind of maybe take their first step?
So there's a few different avenues. First of all, there's some excellent educational modules. So the Ulster University has a PG dip in refractive surgery, which is brilliant, especially if you're thinking of doing the Certificate of Laser Refractive Surgery. ESCRS has some great resources, as does ISRS, which is the International Society for Refractive Surgery. They actually have a very comprehensive refractive course that you can take, which is all digitally provided online as well. The Royal College also has some really good modules on refractive surgery in terms of the e-learning. So one of the things I did during my fellowship was I found a few colleagues within the refractive space, and we actually put together an e-learning module specifically on refractive surgery, lens-based, laser-based. So these are just some resources, first of all, that people can go to learn a little bit more. And that's really, really helpful. There is also the Royal College of Refractive Surgeons and Visual Sciences, but it's Radhika Rampat that acts as their fellowship kind of director, I believe, and she runs, in association with colleagues internationally, she runs a kind of online learning platform with certain kind of webinars given regularly to provide education to fellowship to students in a more structured manner. And they also arrange international placements and observerships as well. So that's a really nice way to consider
start the process.
Starting the process, exactly. Yeah. And I think it's just having the confidence to reach out to people. And that's why conferences like ESCRS are really good, because it puts everyone in a room. And actually, what I love about ESCRS is there's a lot of trainees that attend ESCRS. And so we're all in the same room together. We're all part of one didactic program. We're all in the same area. We're not split up into different kind of departments. And so it's really nice for everyone to be in the same room. And that's where you can start to meet and kind of chat and have those
and also maybe talk to other peers about new procedures, new technology. In your space, do you find technology is ever changing, ever expanding?
Yes, that's the beauty of refractive surgery, is that it's always evolving, and we have some amazing technology already. So at OCL Vision, where I'm based for my refractive practice, we have access to the latest femtosecond laser. So that includes the Zimmer Z8, but we also have the newer Atos laser by Schwind, which is a femtosecond laser that does lenticule extraction. And I would say one of the biggest developments in the last few years is lenticule extraction, or calyx as we call it, was always performed using the Zeiss laser. So that was called SMILE. But now we have Zimmer providing clear, we have Silk by J&J, and we now have the Atos laser, which allows us to do SmartSight, which are also all just essentially lenticule procedures. So we instigated lenticule procedures in the last couple of years at OCL Vision. And that was a learning curve in itself, because when you have the femtosecond laser delivered, they're all slightly different. No one femtosecond laser is the same. And so you spend months, if not years, kind of finessing your results, finessing your energy levels. What are the day one visions? How easy is the surgery? And there's so much involved with bringing in new technology, but also it's really exciting because you're able to then offer your patients the most advanced technologies.
That's what I was going to lead on to the next question, Masara. Do you find that kind of technology, because it's ever changing now, you've got too much and you've got more time, more chair time required to speak to your patients about all the different options and the advantages, disadvantages, which one to go for? They'll be asking you for your advice.
Yes, I think you can never have too many technologies. We love technology within ophthalmology. And I think when you see a patient, you already have a feel for where you're going to go. And you're already, so every time you're, assessing that patient, every scan you look at, the history that you're taking, you're kind of narrowing it down, bit by bit. So by the time you get to the end of the consult, you've got maybe 2 or 3 options. And it really depends on their demographics as well. So I think within the refractive space, I think the most challenging thing is presbyopia. And that's always the longest conversation. As you know, you've got compromises. So for my younger patients, we're looking usually at blended laser vision correction. If they don't tolerate monovision or blended vision, then we're potentially looking at RLE. If they're not quite old enough, you also have the option of implantable contact lenses. Again, that's usually with mini monovision. You have the Evo Viva now, which is like an EDOF version of an ICL, but still with that, you need some offset to get the most vision. So we're not quite there yet. But there are some other interesting technologies like, as you know, corneal inlays. You have Allotex, which is a biocompatible inlay that sits in the cornea to provide enhanced near vision. Although some people don't like to touch the cornea if they think they're going to do lens exchange within a couple of years. You have interesting technologies like scleral laser microperforation, where they're making tiny little holes in the sclera to try and improve accommodation or extend accommodation. Then you have drops in America like Vuity or pilocarpine, which again is really good for those early presbyopes where maybe you're going to delay surgery, but ultimately you're going to do something.
How do you manage patient expectation when it comes to presbyopia and lens extraction?
I think you get a really good initial feel from patients as to whether they're going to be someone who's going to compromise and whether they're understanding of what those compromises are and what their expectations are. And I think most patients come into a presbyopia consultation not knowing that there's any compromise. They think, oh, I'm just going to have laser vision correction, I'm going to see distance and near. And they don't really think about the nuance of it until they're in the room with you and until you're actually talking them through, well, we could do this, but you're going to experience this. I could do monovision or blended vision. There will be some compromise to your distance vision. And if they've always been an emmetrope their whole lives, are they going to be willing to compromise on that?
Do you find that people's occupational demands and visual tasks are changing now in comparison to maybe 5-10 years ago? There's more demand on digital devices, laptops, mobile phones. People are maybe reluctant to give up that kind of blur and sacrifice maybe the faraway vision. Are you finding that in your consultations?
A little bit. I think since there was a big refractive boom and even a cosmetic surgery boom during COVID. because people were spending a lot of time on Zoom meetings, on screens, that kind of intermediate vision. They didn't like the way they looked in glasses. They maybe didn't like the way their eyes looked, because the only thing you could see visually were your eyes when you were wearing a mask the whole time. People were steaming up. And so we did see a big boom actually during COVID. In terms of change to lifestyle, I think we live in a very intermediate / near world now, I think, with devices. A lot of us actually do a lot of our work from our phones now, things that we would have had to do on our laptops or our computers before, answering emails, etc. We're now doing on the go on our phones. And so people have even more demand for better near vision working at that level a lot of the time. And I think when I see patients, it's just getting a feel for what their demands are, what they're willing to compromise on. If I say patients, okay, what's your ideal? It's always, well, I want to see everything with no compromise, so that's not always a very useful thing to ask them.
And how do you go ahead by asking them? Do you do them verbally? Do you have any kind of pre-assessment questionnaires they can fill in? Do they fill anything online? So give you an idea of what they're looking for?
No. We just do it all in clinic. Yeah. And actually our optoms do a really good job of screening patients and getting a feel for them, because they take our histories for us. We're very spoiled at OCL Vision. We work with some amazing optometrists. And so by the time they come to us, our optom will come in and say, look, I've seen this patient. I actually think this will work really well. They also do something called a loose lens test to see what their tolerance is. Their just initial gut reaction to a bit of blended vision. And they say, look, I really don't think you should push any blended vision. I really just don't think they're going to tolerate it, because we know about 30 to 35% of patients won't. And then they'll come in and say, I think this patient's great for a multifocal. And they see a lot of our post-ops. So they actually, they hear a lot of the feedback from patients about their experiences and what they're struggling with, or dysphotopsias. So actually, we're very lucky to have almost like our pre-screening, which is with our optometrist.
And post-op care.
And post-op care. I think I actually have thought about this a lot, about having a pre-screening questionnaire, and I actually think it'd be really good.
Because we do it in dry eye assessment all the time, and it tends to kind of be 2 or 3 very, very famous kind of questionnaires out there which you can use for baseline data, and then prior to treatment, and then commence treatment, and then see what the questionnaires are like. And it's very, very easy.
It's very good.
And patient information leaflets and kind of tend to reaffirm the communication method you're trying to give across to your patient too as well, because people can sometimes forget this miscommunication.
Yeah. Yes, and I think it just forms part of that conversation, doesn't it? Having a pre-screening software kind of primes them to start thinking in the in maybe even at home. You could send them a questionnaire before they even get to the clinic, because I think once you get to clinic, there's a lot going on. They've got scans, they've got optom, they've got you,
anxiety, fear too as well.
Yeah, on the day. So sometimes actually sending them a pre-screening questionnaire, maybe when they're at home and just relaxing, is probably a nice thing to do. And it primes their brain to start thinking, oh, they're asking me about halos, they're asking me about night driving, they're asking me about, okay, and then they start thinking. So when they come into clinic, it's not such a new concept to discuss these types of things. So I think there is something about that.
There's a lot of talk at the present moment on halos and glare and nighttime driving, because all the cars are getting bigger, the headlight kind of, are you finding that in practice, that maybe somebody is talking about kind of, glare photopsia, and it may not be, eye related, it may just be car headlight related?
Isn't there a governmental investigation, I don't know what they call it, inquiry, I think that's the word, inquiry, into headlights? Correct. That's how bad they are.
Yeah.
So as someone who's had LASIK, I do get slightly more glare than I did before. Don't know if that's because I'm looking for it, but even I've noticed that the headlights are really disturbing. Does it stop me from driving? No. If you think about it too much, I think it makes it much more obvious. I think you almost have to learn to ignore it. But I definitely have found patients, particularly those who live in rural areas. So I work in Hertfordshire half the week, and a lot of my patients live in dark roads, poorly lit areas, and they really struggle. And when they're having cataract surgery, you say, well, you should experience an improvement, because a lot of the time they have worsening glare because of cataract.
Yeah, definitely.
However, when you have your RLE patients, your refractive lens exchange patients, who maybe have no cataract at all or very clear lenses, you have to warn them about the risk of halos, dysphotopsias, starburst even, and that, yes, headlights are brighter and more difficult. So you just have to prime them, but reassure them that it does generally get better over time. Because I think those first few days particularly, that they might call up concerned about halos and that kind of thing, but just warn them that with time, reassure them that it does get better, and it often does. And I've not had major issues with dysphotopsia, to be honest.
Can we talk about technology and technology in your practice? Obviously, you said it's changing. What do you find is the best technological piece you have in your clinic?
For a lens or laser?
For lens.
For lenses, I've started using the Galaxy lens, which is a spiral optic lens implant. that provides a continuous full range of vision with less dysphotopsias and halos than a traditional multifocal IOL. And I've been using that lens since October 2024. And it was first used by Alon, who's consults for Rayner at OCL Vision. We were actually part of the multi-center trial that's actually just been published. And I'm finding that lens a really interesting technology because we're able to provide patients with a range of vision from distance to near. It's quite a smooth, continuous, comfortable range of vision, particularly that near to intermediate vision. With multifocals, you sometimes have that dead zone or that grey zone in between. Whereas with this lens, we're finding a more continuous, comfortable intermediate vision, which is very good for things like screen work, as you said.
And patient expectations are met?
Yeah, so generally, what's interesting about this lens is the more you use a technology, the more patients you put it in, the more you learn about it. And I would say it's a really interesting technology because we've not really had something like this before where we're able to offer more range of vision with less dysphotopsias. That being said, it is still a complex lens design. It has a central vortex or spiral. And some patients, as with any lens, will achieve more near vision than others. So it's about priming them, counselling them, and also explaining to them that there is that period of neuroadaptation, which for some patients can take a while, 6 to 12 months. And what we're finding with the Galaxy lens is that the distance vision takes a little bit of time to settle and sharpen up. And sometimes that requires also doing YAG laser in those first 3 to 6 months, as with a multifocal IOL, to get the best vision. So that's a really exciting technology that I've started using with really high patient satisfaction rates. Other things that are exciting are our Atos laser, our lenticule extraction laser, which we're using for our laser refractive surgery. And we're finding that the dry eye symptoms are less with the SmartSight lenticule extraction procedure. And the results are really good. Even our day one visions, a lot of our patients are better than 20/20. And that's the one caveat with lenticule extraction versus LASIK, for example, where the recovery with LASIK is super fast, couple of hours, and your vision can be really, really sharp. With lenticule extraction, it can sometimes take a week to sharpen up. But we're finding with finessing our settings that actually we're getting great visions at day one. So there's a lot of exciting things happening.
Talking about your technology, obviously we haven't addressed ocular surface and dryness and dry eye conditions, and you've alluded to an older population. How do you go about maintaining the ocular surface is appropriate and optimum primed for surgery?
Yes, so dry eye is I think if you're going to become a refractive surgeon, you're going to become a dry eye specialist, essentially. Or if you're going to be doing a lot of private cataract surgery. The reason for that is the majority of our patients that I see have some level of dryness, whether it's our young refractive patients who've been in contact lenses for a long time, over wearing them perhaps, or our patients coming for cataract surgery. I see a lot of rosacea. Don't know why, maybe I'm just looking for it. And I see a lot of blepharitis and dry eye. So you have to be primed to manage that preoperatively.
Manage that first of all.
Every single patient I see, even if they don't have an obvious amount of dryness, I just pre-treat them because we know with these surgeries that it can destabilize the tear film, can make dry eye worse. And so we have a program that we give to all our patients, which includes hot compresses or heat mask, omega-3 or flaxseed oil supplementation. We give every patient preservative-free lubricants. Some patients may even have a course of mild steroid preoperatively. We also have a treatment called Zest, which is really good. You may know about this. It uses ochre-based components to essentially provide a cleansing, cleaning, and anti-inflammatory approach to treating blepharitis. So we bring them in for a Zest treatment, sometimes preoperatively, sometimes even postoperatively. And the patients that have had it have said that their eyes feel very fresh, their eyes are nice and clean for the surgery. It lowers the bacterial load, reduces the risk of infection. And we also offer IPL as well, which sometimes if we're concerned about the ocular surface or the suitability for surgery, we will do IPL preoperatively and sometimes even postoperatively for our patients. I would say one of the most important things with dry eye is counselling patients because they may be asymptomatic but have quite dry looking eyes, and you know with the surgery they're going to become more symptomatic. So I almost prime them to say your eyes are going to be more uncomfortable postoperatively. This is what we're going to do to improve it. And if I'm not happy with the scans, or I think their eyes are dry, or they've got a lot of makeup in their tear film, which is often the case, I will bring them back for repeat scans before the surgery. And you want to improve that refractive accuracy. And we know that K readings are often the reason that we don't land where we want to. So that's really, really important.
Perfect. Thank you for sharing that, Masara.